Okay, we've spent a lot of time looking at behavior and mental processes, and psychologists and mental professionals have spent a lot of time and a lot of effort in learning what abnormal psychology is and the problems that people have. But the main goal, though, a big goal that they have, is to try and help those people through therapy. And that's what this next section is about. It's about therapy. How effective is therapy? What are the different kinds of therapy? What are they based on? You know, there's talk therapies and there's medical therapies, and which one works for which kinds of disorders. Okay, so we'll be looking a little bit at the history of this, and we'll be looking at the modern research on what is going on in therapy today. Okay, coming up right now, Unit 13, Therapy. All right, we start our look at therapies, and basically the therapies are based off of, principles that we've learned before from personality theories. The most common ones that we're looking at, which are most effective, all the therapies have to do with basically the psychodynamic approaches, humanistic, behavioral, and cognitive approaches. So we'll look at the therapies involved in those. To begin with, we start with the psychodynamic and humanistic therapies. So first of all, if you remember the history of treatment, when we talked about mental disorders, we talked about Philippe Pinel, who was the first to really just look at, mental illnesses weren't the devil. We don't have to beat the devil out of people. We don't have to cut holes in their heads. We don't have to torture them to get rid of the evil spirits. And Dorothy Dix was actually a counselor of women prisoners, mental patients that were actually housed with male and female prisoners, and she went on a crusade to reform how we treat mental patients in Europe and in the United States. Psychotherapy is one of the main kinds. We look at either psychotherapy or biomedical therapy. So psychotherapy is what we might call talk therapy, where we have an interaction between a therapist and a client or patient. The biomedical therapies, of course, involve the use of drugs and psychoactive drugs to help them. Most therapists, however, would say they use an eclectic approach. An eclectic approach is combining them. So we might use some kind of, psychotherapy along with biomedical therapy to treat the same illness, and that's usually what happens now. So we start by looking at psychoanalysis. We used to look at Freud, and this comes from Freudian ideas. It was his kind of thing. It's the classic thing where we look at, the psychologist sitting out of view of the patient, and they'll sit there telling their life stories. So psychoanalysis, again, is trying to look at what's inside the person. What are they carrying around unconsciously? The battle between the id, the ego, and the superego. And their goal of therapy is for the client to gain insight. We're looking to gain insight into what is the issue that might be causing the problems that the client will have. Actually, they call them patients. And what they would look for, the methods they would use is, a main one was free association. So free association was the idea you lay on the couch and you just talk about whatever comes to mind when you're out of view of the therapist. And if you think when you tell a story about something, you start to talk and then you'll get to something and then you'll change it. Maybe it's every time you come to talking about your mother, you change the subject or you have difficulty coming up with the words. And what the therapist will see this as resistance, and they will mark it down in their little notebook, and they will put that together and try to explain what it is. If it's every time you try to talk about your mother, you change the subject, then perhaps the problem lies within a relationship with your mother. And the interpretation is usually done after 2 or 3 years of pretty intense psychoanalysis, and usually we're looking at 3 to 5 times a week for an hour. He used to use dream analysis and hypnosis, where you would look at this. This might be a way for the unconscious, the id, to show itself without interfering, without affecting the superego, so then they could come up with an interpretation of what was going on. The other thing they would look for is transference. Often this, if you have, a hate for a parent or a relative or something, or a love, it may be transferred onto the therapist, the psychoanalyst, and so that would also be a clue into what it was. Now, the dream analysis, we talked a little bit about in our states of consciousness unit, and he found under hypnosis it wasn't real reliable, and he thought dreams would really be a good way. But as we can see, there's many interpretations of dreams, and that was an early theory. Our more modern approach to psychoanalysis is actually called psychodynamic theory. The aims of psychodynamic theory are actually to treat the patient in the here and now, not so much about what's going on in the past. However, they will look at it as, which is similar to psychoanalysis, is a pattern of relationships, perhaps with friends or families, that may show up later on in a consistent pattern. A difference with psychoanalysis is this would usually be a face-to-face relationship, and so you would actually speak right to the therapist, and they would be looking for these signs, and it would take a lot less time. Usually it would be basically weeks or months where you would be in psychodynamic therapy. So it went a lot quicker, and there was a lot more the analysis was done a lot quicker. And this is our more modern form of psychoanalysis. Humanistic therapies, if you remember, are humanists. They think self-fulfillment is the goal of people, which is probably very true. And they use what we call insight therapies. These are for the client to gain insight in their behaviors of what they are doing. So what they would try to do is promote self-fulfillment. They would promote growth instead of curing. They weren't actually trying to cure. They were trying to make it possible for that patient to move ahead and make themselves closer to being self-actualized or self-transcended. They take clients to take immediate responsibility for their choices, their actions, and it's conscious rather than the unconscious thoughts that they are interested in. And they're interested in the present and the future rather than dealing with what's happened in the past. So they have ways about going with. So we mentioned Carl Rogers and client-centered therapy. So what client-centered therapy? First of all, they would stop calling the patient a patient. They would call them a client. And so the client-centered therapy was an idea that the client holds their own answers. They have their own answers. And so the idea was to get them to talk and to think about things to the point where they would divulge, what is going on, blocking them from increasing towards self-actualization. So it was a non-directive therapy, and it needed to include genuine acceptance and empathy. If you remember unconditional positive regard, this is kind of what we're talking about. If we give unconditional positive regard to the person, they're more likely to open up and they're more likely to solve their problems. So we used several techniques. A big one was active listening. So the client would talk, and so what the therapist would do is only interrupt to paraphrase or to restate what the person has said, or to ask for clarification, or to reflect the feelings that the client is giving off. And in this way, when you do this with somebody and they're talking, when you paraphrase, they like to clarify further. It makes them think a little bit deeper. And when you invite clarification, they think about, oh, really, what's going on here? And especially when you reflect their feelings. And even if you're wrong in all of these, it causes the person to think a little bit deeper. We'll try an active listening activity in class, and you'll see how this works. Now, the behavior, cognitive, and group therapies, these are a little bit different than the other ones, which we kind of look at, thoughts and unconscious things that you're putting around, you're taking along with you. In the behavior, especially, behavior therapy looks at behaviors. It looks at making you change how you do things. And this is based on classical conditioning and operant conditioning techniques, which we learned about in the learning section. So behavior therapy looks at the now, the behaviors. They're not really interested in causes. They're looking at how do we fix this at this moment. So some classical conditioning techniques. Counter-conditioning is conditioning you in a different way than you have been conditioned. Exposure therapies are one kind of counter-conditioning. And with this, we would use systematic desensitization. Systematic desensitization would be looking, say it's an anxiety that you have. We would say or a phobia of spiders. We would, create a hierarchy. What is the most frightening thing about a spider? and to the least. So maybe a picture of a spider would be the least frightening, and the most frightening along the hierarchy might be a spider crawling on you. So what we would do is give, techniques for them to relax, put them in a position, and maybe bring out a picture of a spider and let their heart rate and everything go up, their sympathetic nervous system kick in until it brings itself down. And then we would just progress through that hierarchy until we get to the point where we're actually letting that spider crawl on the person. And it is quite effective. Now, virtual reality exposure is kind of the same idea. There are situations we can't put people in because they're not safe, or we can't get them to do it. Somebody afraid of flying in an airplane, we can give them virtual reality glasses and we can put them in that same position, and it is just as effective as the actual situation. Okay, so the other kind of counter conditioning that we look at is aversive conditioning. Aversive conditioning is conditioning someone to not like something. So, for example, when we look at the alcoholic, you might remember this example from learning, where we would give an alcoholic, their favorite drink, but we'd slip a drug in there that will make them nauseous. And so the person will drink the drink, they'll get sick, and eventually they'll be conditioned to not like it. Now, in this case, the unconditioned stimulus is the drug. The unconditioned response is nausea. In this case now, once we've paired it with the alcohol, it becomes a conditioned stimulus, and the unconditioned stimulus is the drug, which causes the unconditioned response. Okay, so we have now we make the conditioned stimulus alcohol, and they become nauseated. They don't want to drink this. You will remember their other concepts, though. When they're out of this type of thing, if this was the only treatment they had, they'll be around alcohol without the unconditioned stimulus and response, and so eventually extinction will take place. And also cognitively, they are aware that it's the drug that they're getting sick of, not their alcohol. So sometimes it won't work. It might work to help detox, but you probably need more kinds of things. Another kind you might be familiar with is behavior modification. For example, a token economy. A token economy is the idea you get something. This is usually done in institutions. Behavior modification for a person, say with autism and stuff, or OCD, would be done, on an individual basis, where the behavior is reinforced or punished immediately or ignored. In a token economy, this is like where you do something good, you get a point, or you get a little chip or something that, and once you collect enough, you can trade in to get something. I know a lot of elementary school classes would use these kinds of things. Hey, if you used it in your class, how well did that work? You probably found it work for a while, but eventually it kind of takes its course. Now, criticisms of behavior modification is how durable are these behaviors? Once we leave that, once you are not reinforced for something or punished for the wrong thing or ignored, how durable are those new behaviors that you've learned? Will you just go back to what you did before? And the other question, is it right for one human to control another's behavior? In behavior modification, we're looking at behaviors that we choose for that person. So we're denying them something that they want, and we're deciding what are the things to be reinforced to change the way that they do things. We're going to leave it right there. We'll get into the cognitive therapies next time. And so we'll see you guys in class. Bye for now.